Hi, I'm Rishita Prabhu and I'm going to talk to you about pancreatitis today. So, how I'm going to do this is by first introducing the pancreas and its functions. Then I'll talk about how it develops, which is its pathogenesis, and some of its causes as well. After that, I'll run through some signs and symptoms of it along with some investigations. I'll also talk about how the severity of acute pancreatitis is calculated. Finally, I'll go over some management strategies along with some complications of pancreatitis. So, the pancreas are in the upper regions of the abdomen. It is a mixed gland, which means it carries out endocrine and exocrine functions. The endocrine cells are in what's called the islets of Langerhans. There are 5 types of cells. You have alpha cells, which produce glucagon, and that helps increase blood glucose levels. So, it's the body's mechanism to prevent hypoglycemia or low blood sugar. Then you have the beta cells, which produce insulin, and that helps with the uptake of glucose into the cells, so that will prevent hyperglycemia or high blood sugar. Then you have the delta cells that produce somatostatin, whose key function is to inhibit the release of pancreatic hormones and enzymes. Epsilon cells release ghrelin, and that triggers hunger. Finally, you have the PP cells or F cells, which release pancreatic polypeptide, and that aids with digestion. The exocrine section of the pancreas is to produce enzymes which aid with digestion. These include protease, which break down proteins, pancreatic lipase, which breaks down fats, and amylase, which break down carbohydrates. These enzymes are synthesized and stored and secreted by acinar cells. Once these enzymes are secreted, the ductal cells modify the composition of the enzymes, which helps neutralize stomach acids and creates an optimal environment for digestive enzymes to function. What is pancreatitis and how does it happen? Pancreatitis is the inflammation of the pancreas, and it can be classified as either acute, which is short term, or chronic, which is more long term. Acute pancreatitis happens when there is premature activation of the pancreatic enzymes. Normally, the acinar cells produce pancreatic enzymes in an inactive form called zymogens. Once food enters the small intestine, the zymogens or the inactive enzymes enter the duodenum, which is the first part of the small intestine. At the same time, another enzyme called trypsinogen is released. Trypsinogen is an inactive enzyme that has to be activated into trypsin. To help with this activation, another enzyme called enterokinase is released. Trypsin is an enzyme that helps with the activation of pancreatic zymogens into its own respective active enzymes. This is what should normally be happening. However, in acute pancreatitis, the zymogens are already activated in the pancreas, and this can be toxic to the pancreatic cells and cause autodigestion, where they destroy its own tissue and cause inflammation. This premature activation can be triggered by ductal obstruction because it creates an environment to do so. Chronic pancreatitis happens when there are repeated episodes of acute pancreatitis. Continuous insults to the tissue can cause fibrosis or scarring, which will obstruct the pancreatic ducts and will cause premature activation of zymogens. Chronic pancreatitis can also cause damages such as scarring of fibrosis, loss of acini, and stenosis or narrowing of the pancreatic ducts. The causes of acute pancreatitis can be remembered by the mnemonic I get smashed, and that stands for idiopathic causes, which just means unknown causes, gallstones, which causes obstructions of the pancreatic ducts, ethanol or alcohol, which is toxic to the pancreatic cells. Things like trauma, steroids, mumps, autoimmune diseases, and scorpion venom can also cause acute pancreatitis. Hypercalcemia, which is high calcium concentration in blood, or even hyperlipidemia, which is high levels of lipids, are also associated with acute pancreatitis. A procedure called endoscopic retrograde cholangiopancreatography, or ERCP, is a procedure that combines upper GI endoscopy and X-rays to find and treat problems in the bile and pancreatic ducts. An upper GI endoscopy is when they pass a tube through your mouth to reach the duodenum to visualize the structures in the process. So ERCP combines this and X-rays to visualize and treat problems in the bile and pancreatic ducts. This procedure comes with a risk of causing acute pancreatitis. Certain drugs and medications can also cause acute pancreatitis. Chronic pancreatitis can be caused by repeated episodes of acute pancreatitis. Things like alcohol abuse, hereditary pancreatitis, and cystic fibrosis can also cause chronic pancreatitis. Hereditary pancreatitis is a genetic condition that causes recurrent attacks of acute pancreatitis, which eventually progresses to chronic pancreatitis. Cystic fibrosis is also a genetic condition that causes thick and sticky mucus that has the potential to block the pancreatic ducts, leading to enzyme retention, premature activation, and repeated inflammation. Over time, this results in fibrosis, scarring, and loss of pancreatic function, which is essentially just chronic pancreatitis. Acute pancreatitis can be quite painful and can cause upper abdominal pain, which can also radiate to the back. It can cause nausea and vomiting, and also jaundice, which is a yellow discoloration of the tissue. Two textbook signs of acute pancreatitis is Gray-Turner's and Cullen's sign. Cullen's sign is when there is a swelling or edema along with bruising around the umbilicus or the belly button. Gray-Turner's sign is when there is bruising on the flank. Chronic pancreatitis can manifest as weight loss, jaundice, steatorrhea or fattened stool, and diabetes mellitus. Steatorrhea is caused because pancreatitis can prevent the ability of the pancreas to produce lipase, which helps with the breakdown of fats. So, fats remain undigested and are unabsorbed, which leads to the presence in the stool. Diabetes mellitus is caused because of the damage to the beta cells, which produce insulin, and insulin is what helps cells take up glucose and prevent high blood sugar. For investigations for acute pancreatitis, you'll mainly want to do bloods. You'll check serum lipase and amylase, where serum amylase will be 3 times the normal level. A serum lipase might be more accurate but isn't always available, so a serum amylase may usually be done instead. Then you'll do a liver and a kidney function test along with inflammatory markers. Inflammatory markers just help identify if there is any inflammation happening anywhere in the body. If in the liver function test, the liver enzymes and bilirubin is raised, it may signify the presence of gallstones. Levels in the kidney function test and inflammatory markers may also be elevated. You do not always have to do imaging, but if it is required to be done, a contrast computerized tomography or contrast CT is preferred over magnetic resonance imaging or MRI. A contrast CT is when a dye is administered into a tissue prior to getting a scan to help produce a clearer image. It is only used if a physician suspects complications such as pancreatic necrosis, which is death of the pancreatic tissue. It is usually done only after at least 72 to 96 hours after the onset of symptoms. For chronic pancreatitis, a liver function test is also done. They may also check a patient's HbA1c levels. HbA1c basically measures the amount of glucose that is attached to the hemoglobin over the last 3 months. As I mentioned in the previous slide, patients with chronic pancreatitis may develop diabetes mellitus, so it may be worth checking HbA1c levels. Fecal elastase or pancreatic elastase is an exocrine hormone that doesn't get degraded during intestinal transit, unlike the other pancreatic hormones, and it's passed in the stool, so its stool concentration can help reflect the exocrine functioning of the pancreas. For people with chronic pancreatitis, it may be lower than normal. The modified Glasgow criteria. So this is the scale used to assess the severity of acute pancreatitis within 48 hours of admission. The criteria of the scale can be remembered using a very convenient mnemonic, pancreas. PaO2 refers to oxygen content in the blood. Lactate dehydrogenase is an enzyme that may indicate tissue damage, and albumin is a protein in blood plasma. Each criteria is considered positive when they reach certain levels, like you can see on the right, and each positive criteria gets 1 point. For patients with diabetes mellitus, you'll overlook the glucose criteria, and for patients with kidney or renal impairment, you'll discount the raised urea criteria. If a patient has a score that is greater than 3, it means that they have severe pancreatitis. So how would you go about managing it? It doesn't have a cure as such, so you're going to provide them with supportive treatment where you relieve their symptoms. For patients with acute pancreatitis, you'll first want to treat the underlying cause. So for example, if they have gallstones, you'll want to address that first. Then you'll do something called a drip and suck, which is when you give the patient intravenous fluids to prevent dehydration and then remove the stomach contents through a nasogastric tube to reduce the stress on the pancreas. A nasogastric tube is a tube that's passed through the nose into the stomach via the esophagus. You'll also want to provide them with pain relief because it can be quite painful for them. Antibiotics may be given if there is pancreatic necrosis or death of the pancreatic tissue. Patients with chronic pancreatitis will need to stop smoking and drinking because that will just worsen the condition. They'll also need some sort of analgesia or pain relief. You'll want to provide them with replacement pancreatic enzymes and insulin as well, since their ability to produce them has been impaired. Finally, the complications of pancreatitis. As a result of inflammation from acute pancreatitis, tissues may die, which is what we refer to as pancreatic necrosis. The body may also try to create a wall around the site of inflammation, which leads to the formation of pseudocysts, which are fluid-filled sacs, and also abscesses, which is an area filled by pus or debris from fighting off the inflammation. It may also cause something called prehepatic portal hypertension, where there is increased venous pressure in the portal vein, which is the vein that carries blood to the liver. This increased pressure is caused by inflammation and scarring of the portal vein. It may also cause something called acute respiratory distress syndrome, which is when there is excessive fluid in the lungs, which impacts gas exchange. This happens because inflammation can make blood vessels more permeable, so fluids from inside the blood vessels can move out into the lungs and cause acute respiratory distress syndrome. Chronic pancreatitis can cause maldigestion, malabsorption, and malnutrition because of the patient's inability to produce enzymes to break down things like fats and proteins, so they aren't able to absorb any of it, which causes these three symptoms. They may also develop osteoporosis, which is a disease characterized by reduced bone density. This happens because vitamin D is required to absorb calcium. However, vitamin D is a fat-soluble vitamin, which means it needs fats to get absorbed. Pancreatitis impairs the ability to digest fats, so vitamin D isn't absorbed, and hence calcium is also not absorbed. Low calcium levels can cause loss of bone density. Last but not least, chronic pancreatitis can cause pancreatic cancer. This is all I have for you today. Hopefully you've understood everything I've covered and has helped give you an introduction to pancreatitis. Thank you.